Any new people today? Is there anybody for whom this is? Jill? Yeah, I thought maybe Jill might be. Yeah.
Yeah. Can you hear me okay?
Yeah.
Oh, that's a miracle for my PC. Oh, it's the first time in weeks. My name's Jill. Hi, everyone. I'm the CEO of Children by Choice. So I'm so delighted to receive an invite and to absolutely connect with you all in Victoria and hear about all your good work. Thank you so much for having me along. I really appreciate the opportunity.
Oh, that's great, Jill. We knew that you had taken over the job, so that's fantastic.
Yeah.
How are you settling in?
I think that I'm as settled as I will be now. I'm a few months in, so my feet are definitely under the table, and yep, definitely feeling the hot seat, but in the best possible way. It's such a brilliant organization, and I'm so proud to get the opportunity to lead it temporarily, this gal of C by C, and it's just so much challenge and opportunity. So I'm super stoked about it. So yeah.
Well, I know that my my colleagues and my team down here in Melbourne, we always look forward greedily to the Children by Choice conference. So we were just talking at our team meeting today about getting in their preferences as to who goes this year.
I don't mean to, honestly, I'm not in a marketing way, but we are getting close to selling out all our tickets. We think we will in the next 3-4 weeks. So if you're thinking about it, please jump in and get a ticket. But
you may as well use this as a marketing opportunity. Do you want to remind everybody online the dates?
It's the 8th and 9th of August up here in Brisbane. The guest speakers are really great, but in terms of just the content of research and to be able to get those 2 days in front of like-minded people is just phenomenal. So we're really looking forward to it. I don't know if anyone has been on our abstract review panel or any of that, but the session plans are generally out at the moment. The conference theme this year is action for access, and that's certainly in the background of Queensland's post decriminalisation, but we're fast forwarding, and access is absolutely just abysmal in Queensland from a public perspective, and particularly our geographical location stuff. So that's from our perspective, but certainly some fabulous research around and presenters from regional communities, as well as nurses and midwives and conscientious objecting. We'll also do if you know Catholics for Choice, they'll do a session a day prior to our conference, so kind of like a sideshow, if you like, really talking about moving conscientious objecting out of, or values clarification training from the Catholic Church's perspective. So really very fascinating in terms of the pieces of work, and they're coming over from the US. They deliver this kind of stuff around the world. We'll be presenting in our main conference as well. Yeah, just some really brilliant opportunities. So if you haven't booked, please do. Love to see you.
I've just put the link there in the chat.
Thank you.
For anyone who hasn't got it already. I'm sorry, honey. I'll let you talk because I've just got to send this to someone.
Oh, okay. We're just somebody wanting to join in. Yeah. Well, look, we may as well open because it's 6:05. So sorry, I have got a serious frog in my throat. I'm sorry. I'll just keep sipping. And welcome to tonight's meeting. I'd like to start with a formal acknowledgement of country, and to state that we here at the Women's acknowledge and pay our respects to the people of the Kulin Nations, the traditional owners of the country on which we are broadcasting from this evening, and also acknowledge that this being a webinar, we are on many different lands, and to acknowledge the peoples of the respective lands on which you all are all listening from this evening. It looks like we've got a good turnout tonight. Kath and I were joking with people as we were just arriving that we're both back from holidays just in the last couple of days and have both managed to injure ourselves. But all joking aside, we just wanted to acknowledge that we haven't had a lot of time to prepare a specific topic for this evening, and we thought it would be a good chance for us to basically go around and do a bit of a catch up. We'll also do a little bit of a focus on the budget and opportunities and opportunities for us to grab to try and promote and advocate for primary care delivery of sexual health. So we've already met Jill from Children by Choice. It's her first time with us. Is there anyone else who is a newbie who we haven't seen before? Could I ask, there's a couple of people I don't recognize. Is Firefly's note taker Paul? Is that Paul Braun? Who's Firefly's note taker? Could you just tell us who you are? Given the nature of this, if someone's completely blacked out and we don't recognize them, we always ask, and it's not a challenging way, it's just we just want to know who's online.
I have asked them to unmute, but I'm not sure.
Anyone else? You? No? I think we'll just start. I really would like the person who's identified as Fireflies to identify themselves and tell us where they're from, even in the chat. It's not Brom, he sends his apologies. So it's another Paul. And we'll start with Carolyn Mockarbel from 1-800 My Options for a bit of a Victorian roundup, how things are in the sector.
Thanks, Patty. Hi, everyone. I'm Carolyn. I'm the manager of the 1-800 My Options service at Women's Health Victoria, coming from you from Wurundjeri land. Sorry, I'm a little bit tired today. I've got a kid with the flu, which sucks, can I tell you? But 1-800, we're really busy. We've had this busy period that's been going on for a couple of years now, but it really amped up at the start of March when one of the private clinics in Melbourne stopped providing surgical abortion services. Since then, from what I understand, they're also not providing medical abortion services either. And so there's been a bit of a gap in the southeast. And so we're currently receiving calls that are often 20 or 30% above what we'd normally expect from the last couple of years' increase. And in particular, when I look at the data, a lot of the calls that we're getting are from that southeastern area. So when I had a look very briefly today at our calls to the end of May, we'd already exceeded what we'd received from some of those southeastern suburbs in the entirety of 2023 in those first 5 months of this year. So there's definitely a big gap in the system out in the southeast. And although we've had these amazing hospitals commence services and really start to meet demand and start to be incredibly responsive to the needs of abortion seekers, we're still seeing a lot of pressure in the system. And it's made worse by this cost of living crisis. So 35 to 40% of our callers at the moment can't afford sexual and reproductive health services. And so when they're being quoted really significant prices for either medical or surgical abortion, that makes it really very difficult for them to afford things. And even for the public system, if a person needs to get a GP referral, get an ultrasound, often all of those services have a cost that can be really unaffordable for people. So the busyness continues. We've also got a really cool project that we're doing at the moment. So Women's Health Victoria runs both 1-800 My Options and the Victorian Women's Health Atlas. And what we're doing is we've employed a data analyst to look at the data from 1-800 My Options for the first 5 years of service, as well as the data from the Victorian Women's Health Atlas, to see what the trends are looking like across the system, both from a service seeker point of view and from the PBS and MBS item numbers that we've got on the Atlas, which are looking at medical abortion provision and long-acting reversible contraception provision. Because the Atlas has so many data indicators, we can also look at various socioeconomic factors alongside that. And some of the things that we're starting to see from that are around differences. I can't really share the data just yet because it's not finalised, but we are starting to see some significant differences in service seeking between rural and metro areas, as we'd expect, obviously, but also differences for age groups and differences for people who are eligible or not eligible for Medicare. So we're really hoping that we will have the reports finalised at some point July-ish or August. There'll be a statewide report looking at all of this data, as well as regional reports for all the regions in Victoria. And so it'll be really great to be able to share it with the group. Hopefully it'll be a useful tool for advocating for service access across the state. Thank you. You're on mute, Patty.
Sorry, Carolyn. Thank you as always. We had also been getting reports from Frankston or Peninsula Health Hub, as it's called, about a very profound increase they have in inquiries and almost a 300% increase in their caseload. Since Hampton Park shut their doors. So we have been aware of that, and we haven't been so aware of it at the Women's because we're so geographically remote from that area that we're not that much of a help. Have seen some patients, but we've certainly heard that from the Frankston team.
Yeah, one of the things that we're finding as well is a lot of GPs are continuing to refer their patients through to Hampton Park. We are going to be putting some notes in the PHN newsletters just to remind people that the service system has changed pretty significantly, probably since the last time they looked at their health pathways or the last time they looked at the 1-800 MAP, particularly with public provision being expanded more. So, another of the things that we're seeing from the 1-800 My Options data is that generally, GPs are not providing enough workup for their patients when they're making a referral through to a public hospital. I know you know about this really well at the Women's, but it seems as though only about 40% of our callers have appropriate workup when they've seen a GP. And it's just slowing things down for people often and creating longer wait times for them when they have to go back to the GP to get referrals for blood tests and ultrasounds again. It's obviously a bit of work that we need to be doing with the system to remind people that if someone's presenting, these are some of the things that they could be thinking about doing, whether they've decided on an abortion or not.
Have you reached out directly to the South East Melbourne PHN? Because as far as I'm aware, it's one of the few PHNs that doesn't give access, it doesn't have a health pathways program. And so I'm not really, I work in the South East Melbourne PHN, and I'm not sure where my colleagues are actually getting information about how to refer on if they don't provide themselves. And the other question I had was, could you give us an idea of how many private surgical providers there are in Metro Melbourne at the moment?
Yeah, absolutely. So in terms of where people get the information, that's a really good question. I thought that South East Melbourne PHN had like a version of Pathways, which is like PDFs basically to direct people, but I might not be right on that. In terms of how many services there are providing surgical abortion in Metro Melbourne, we've got two of the big private clinics that everyone's really familiar with are Fertility Control Clinic and Murray Stopes, or MSI, I should say. there is 1, 2, 3, 4, 6 public hospitals across Melbourne with differing levels of provision. So some of them are providing weekly lists and some of them are not. And then there's a small smattering of private gynecologists.
Yeah.
The real issue is for people who are needing a low-cost service and may not live in the catchment of a public hospital. If that public hospital has a catchment that they enforce, that can make access really difficult, or if someone's second trimester, because access is incredibly limited at that point.
I'd suggest that given the closure of Hampton Park, it would be good for somebody to reach out to the CEO of the PHN. I'm happy to do an introduction and say, look, this is a real issue. This is what's happening. What's your PHN doing about it?
Yeah,
That's
that's
a
really
good thought, Danielle. Our experience with regard to the pathways is that they're very rarely used. You know, so even when they exist, we get referrals of about the same standard, which is just a no workup or minimal workup. So it's pretty hard to sort of keep on bashing on about that. I think it's maybe a hopeful referral, hoping that because the patient hasn't been able to access it, that the public system will absorb the costs. I imagine that's the case for quite a few of the referrals anyway. But it'd be a good idea to reach out to the PHN. We'd be happy to do that.
Because I'm thinking there's other channels of communication too, like they'll do a newsletter, electronic newsletter routinely to GPs, so that might be a way of.
It seems phenomenal that the GPs aren't aware that it's closed. It just was such a big coverage, wasn't it? But yeah, good point.
Yeah,
good
but
point.
thanks. Any introductions you can make, and we can work with 1-800 My Options to support either in a development of a health pathway or yeah, just some relevant clinical information that would support a referral.
And with regard to the other 2 private clinics, I have been in contact with one of them today, and they're the other one just before I left, and they're both really struggling in terms of workforce. They're asking if we've got any capacity to help out with coverage for their staff. So they've got big holes in their coverage and recruitment problems that we're trying to help with. But yeah, it's a shrinking supply, definitely in private. Has anyone else got any other comments for Carolyn? Yes, Siobhan.
Can I just ask a question? Kind of, it's something that I only know from an anecdotal perspective. So out at CoHealth, patients will be directed to the nurse, and then she gives them a very comprehensive overview of what to do and sends them either to one of our GPs or to their local, and tries to get them into their own GP, books them in with me, and then they disappear. And my presumption is that they are still having their medical termination, but they've gone to the GP and the GP's gone, I can do that, which I kind of take as a good thing, but I don't know whether anybody's got any evidence of it. Maybe I'm just convincing myself that, yes, that's worked well. But I don't know whether Carolyn has any evidence of that, or is there any way that can be tracked? I mean, maybe they're all going off and not having it, but I don't know.
I'd like to hope that that's the case, and we do know that we know that medical abortion numbers are increasing year by year. But when we look at the PBS data, and it doesn't, the PBS data that we have on the Atlas is only to the end of 2022, but we can look at PBS data more recently just to see what the trends are from a Victorian whole of Victoria point of view. And there isn't a significant increase that we've noticed as we look at that a little bit since the deregulation, or so I'm not really quite sure that it's the case. I will say there are some great medical abortion prescribers in the Western region, so potentially those people are going out
Yeah.
to those other services that are also, there's a few that are more affordable as well. So hopefully that's taking some of that pressure off CoHealth.
Yeah. Cool.
Mm.
I just find it interesting when they, you know, they don't turn up and there's been this whole palaver.
Yeah.
And Madeline follows them like, you know, like she's really good at that stuff. And then it's like, oh, okay. So I just hope that it's a good ending all round and they're getting a good service somewhere else. But of course we don't know.
It certainly would be much better for the consumer if it was a one.
Yeah.
You know?
Yeah. Totally.
I had a question for you, Carolyn. Any more activity on your health maps, your atlases?
So we will have some new data coming up soon. They've recently added confidence intervals to some of the data sets that came from the Victorian government, which is really interesting for some people, not as much for others, but I think it's really useful to have.
Yeah.
We are looking at having the 2023 medical abortion and LARC data up either at the end of this year or early next year, but we're also looking at adding hysterectomy and caesarean section to the map, which is going to be really interesting, particularly looking at those hysterectomy figures next to LARC provision. So end of the year, start of next year are hopefully the dates when we'll see those. And looking also at indicators around what we might be able to put for endometriosis, which is a bit tricky, but looking at what might be possible.
Excellent, excellent. What we might do now, Kath, is have a bit of a chat about the state and federal budgets for 2024 and how they might present some opportunities. And thank you to Sphere Danielle for a nicely constructed and beautifully worded update on what it means for us. I can talk to that, or you might like to speak because you wrote it.
Straight to the source.
Are you happy for me to just sort of talk about the main dot points of what has been announced? That there's going to be a focus on MBS item numbers to support nurse practitioners requesting ultrasound scanning. I would, given that you're here, Danielle, could you explain, you'd mentioned that it's a new 60-minute Medicare benefit schedule. What does a 60-minute Medicare benefit mean?
So I think you know, we've got in the schedule level A, which are very short consultation, under 5, B's 5 to 20, C's 20 to 40, D's 40 to 60, and now there's a level E as well. And I think the minister's got in her mind that you know, very long consultations are worthwhile, and so general practice got a long consultation last year. Specialists got one in this budget for endometriosis, but can really be used for anything. And now nurse practitioners as well. So I think that's the thinking is that women require these very long consultations. I'm not really 100% personally convinced about that, but if they want to put in a long consultation, you know, it won't do any harm, but may help.
Well, I misunderstood that. I thought it was they were referring for like a 60-minute ultrasound, you know? No, so it's not the item number for an ultrasound. But is it also correct to say that nurse practitioners are able to request the ultrasound? Yeah.
So there's a whole lot of support for nurse practitioners in the budget. There's a very large round of scholarships that have been introduced for nurse practitioners to train more nurse practitioners and midwives. and to create endorsed midwives so that they can pick up a lot of the work in and become independent abortion providers and hopefully lark inserters as well. So I think that's the plan, but there isn't the workforce at the moment, you know, so it's a way of building capacity.
So one of the scholarship funds is with regard to primary care health professionals undertaking training in insertion of IUD services, IUD devices.
Yeah.
And it says that the scholarships will support travel, and course costs.
Yeah.
And we, this is just an example of us sort of thinking outside the box and maybe trying to flip that, you know, we're aware that a lot of the courses are centered in metropolitan areas, and that it's hard for practitioners to give up time, etc. And it's costly to come down, for example, from Echuca to Melbourne to do a course. Kath and I have done several trips, as you know, to some of you, and done on-site IUD supervision of your own patients, and we find this to be a really successful model. So we were just thinking this afternoon that we would develop, in response to this item, that we would develop a course outline which involves the practitioners or supervisors traveling to the practitioners who want to learn, rather than it being the other way around, and utilising this scholarship funding to do that, because we've been looking at ways to kind of promote the travelling roadshow a bit more, because our funding's really limited. But this might be one way that we could you know, turn it around and make it actually less costly, because it would only be 1 or 2 people traveling. So somebody's got their hand up. Amy, Clinic 281.
Yeah, thank you. Hi.
Hello.
I'm just sorry, I can't put my video on because our internet's really dodgy and you won't hear me at all. I'm just curious about, as far as we're talking about consultations. Now, as a nurse, can we do a lot of the pre-workup, and then when they go in and see the GP, whether it be for contraceptive or whether it's the MTOP or whatever, can the GP then also use the time that the nurses as part of their consult, or can they only charge, say, like a 23 if we've, like, you know, a shorter consult if the nurse has done the initial workup?
Nurses' time.
Yeah, so to sort of speed up, or if the doctor's busy with one and the nurse starts, you know, asking all the questions and doing all that, getting all the information to sort of speed up the time with the GP, is the GP able to, now this is a question that we had, I'm not sure if you can answer it or not, or someone is able to, whether they can then use that as still a long consult because the work's been done, or whether it's only if the GP spends that whole time with them that they can claim that longer one.
I'm sure somebody else on the webinar can answer that. That's a really good question.
My understanding is that's exactly right. Yep. They can only charge however long that they see them. So we have this model all the time in Bendigo, and it's usually around the volume. So we have lots of nurses doing lots of preparations for a whole lot of things, MTOPs and all the pre-Mirena, pre-LARC, and then the GPs pop in and do the scripts, or they do the some further investigations, and then basically we triage the more complex issues or clients with the GPs. So that's been working in Bendigo now for 8 years.
But if I'm reading this correctly, you would be able to charge the 60-minute Medicare benefit now as a nurse practitioner for that?
When it comes in, yes, a nurse practitioner will be able to do that.
Is, now that I've understood what the 60 minutes means, that will be really quite useful for you. But
absolutely,
it's nurse practitioners only, is it? It's not for other nursing colleagues?
No, so no other nurses have Medicare items, and nurse practitioners are only time-based. So at the moment we only have 3 time-based, consultations, and this will give us a fourth
Yeah.
time-based consultation. Yeah.
So that's good, but from your point of view, Amy, I don't think that it can be included in the doctor's time.
Not familiar with the MBS numbers and how that system works, but I think this is part of the rationale for the hubs, that the nurses are funded through a different stream that's not MBS. And so, yeah, they're EFT funded from whatever stream it is within the state health department. So, yeah, and obviously working alongside doctors, but yeah, they're not able to you know, align their work with the MBS claim that the GP does.
Yes, GP practices get practice incentive for all their practice nurses. So whether that's an enrolled nurse who does you know, kind of immunisations, or whether it's a very senior women's health nurse who does a whole lot of things, it's they're very linear, which doesn't really reflect the work.
But the likes of Amy's clinic is a hub, and so you would be getting that different funding stream.
That's right, yeah.
Yeah.
Melanie had a hand up.
Melanie, did you have your hand up, or was it a scratch?
I was simply going to just reiterate what's already just been said. 15 years in GP land, and yeah, they can only claim the MBS for their time. So I was just saying the same thing, unless you're a nurse prac, just the nursing side of things. No, that's the nurse incentive payment.
Suzanne's got her hand up too. Suzanne Wallace.
Suzanne.
Suzanne Wallace had her hand up too. Suzanne, did you? Yep.
I was just going to say something of what Louise has just said, but also say that we have, as a nurse practitioner, we have no procedural items, so that what the longer consultation will be, where now if we see someone that we're just doing MBS, so bulk billing, to put an Implanon in or even change an Implanon, the most we would get would be about $50. And that's purely our longest item number. So this will potentially make that maybe slightly more reimbursement, but
right, so you could charge a time-based
procedural items, then it's difficult.
And is there any word on the timeframes for implementation of these changes?
There's no word on that, and there's no word on the process that will be used.
Yeah.
To manage the scholarships, or what courses the scholarships will be for, or anything like that, in relation to LARC insertion. So the scholarships for nurse practitioner and endorsed midwife training are going through the professional colleges, but the LARC insertion, it's yet to be determined, I think, and you know, I hope to encourage the health department to set up an advisory group about that.
We'll just have to watch this space.
And it's my understanding that the nurse practitioner scholarships are going through the Victorian Health Department. They're the body offering scholarships for nurse practitioners. Or is that not right, Danielle?
So my understanding is that Jed Carney in Bendigo announced the scholarships for $15,000 for a senior nurse to do a graduate certificate, and then $30,000 for a nurse who was eligible to do to do their masters, and that's going to be managed by the Australian College of Nurse Practitioners, and it's federal funding.
Oh, right. So that's in addition to the Victorian government.
Yeah. So this is money for the actual nurses to actually fast track, because you need to do your masters as a nurse practitioner, and a lot of very experienced nurses don't have a graduate certificate or don't have a graduate diploma, so they need to do both.
But this next lot of scholarships is specifically around inserting LARCs as well for primary care providers, so that's not specifically targeted at nursing or nurse practitioners, but at all primary care. So it looks like there's quite a few in the Venn diagram. There's quite a bit of overlap, and it's going to the devil's going to be in the detail and how we would be able to maybe utilize that scholarship offer. I know that you know, the women's, it took a very long time before the nursing administration could understand how they could use the scholarships for nurse practitioner funding even, you know. It's taken a long time for these things to settle down. The other initiatives have included $1 million for the development of a virtual contraceptive decision-making tool. So instead of a handheld page that we've all laminated over the years, to have a virtual decision-making tool. So that would be interesting. Again, not much detail on who's developing that. And a $5.5 million support for the Australian Institute of Health and Welfare to develop a new database on sexual and reproductive health to give a better picture of what services are being delivered and where there is unmet need. You know, we're always talking about that we don't have enough data on demand versus supply, and the ongoing numbers of abortions. So there's some things that really need to be applauded, but as Danielle says, we've got to wait and see how these things are going to roll out and keep our eye on it. Kath and I are meeting with the Department of Health again very shortly, next week or the week after. Yep. Yeah, to discuss the budget implications in Victoria as well. And I guess we're pleased to be able to announce that we got funded for another year to the team. We go from year to year, but we have been funded for another year. So we'll be bringing up some of these agenda items to see exactly how we are going to be able to flex some of these opportunities to continue the decentralization work.
And also in terms of the implementation of the new hubs that have recently been announced, and there's still, if my maths is right, at 6 or 7 still hubs still to be announced to take us up to 20 by next 12 months.
Yeah.
Yeah.
Have we, in our previous meeting, have we announced the last 3 hubs that we're?
I don't know what happened yesterday, Patty. Sorry. So we, but maybe we did. Sorry. It's but it's Nexus Health and DPV, and oh my God, I can't think of the third one. Caroline, are you there? Can you help me out? Oh, Sunraysia. Oh, Melanie, sorry.
Terrible, isn't it?
Sorry. Do you want to talk about, we're just about to go into updates if that's okay? Yeah.
So we'll walk into updates.
Yeah, Melanie, why don't you morph into telling us how you're going and who you are and what the service system looks like up in Mildura.
Okay, evening. Hi, everybody. My name's Mel Jamison. I am the Women's Sexual and Reproductive Health Hub nurse, and I think we were hub number 13 or 14 to come out of the 20, and I commenced in my role in February of this year. My background is mostly in GP land, but I've been doing sexual health and PAPs and implanons and immunisations and stuff for many years. So I was able to bring that over into community health settings. We're based out of a community health service. My position is also has endorsement for the nurse prac pathway. And so I have written down Sue and Louise's names in here going, right, they're 2 ladies that I would love to follow up with. And yes, I'm starting my certificate for sexual and reproductive health next month through Melbourne Uni. There is no diploma anymore. The only one was La Trobe, and that's on pause at the moment. So I'm starting that to then head into my master's for my nurse prac after that. In terms of services and stuff we have here, so I'm doing contraceptive consults and working up for those. We don't have GP support here at the community health centre, which makes it really tricky. I feel at times quite dead in the water with things. I can only go so far, and then I'm having to try and refer back or implement back. Yes, I also was a forensic nurse with from Victorian Institute of Forensic Medicine for 5 years as well. I finished up with them in October, I think, last year. To that question, I pretty much did everything this side of Witchy, Horsham, Swan Hill, Mildura, and it was just me. It was a big intake and it was a lot. So yes, I do have a background in forensic nursing as well. And so I'm doing Implanons. I have linked in really nicely with Family Planning Victoria, who now do their telehealth abortion services. And I've basically set up a direct line with them, so they support me with that here really, really well. So that's really good, even in terms of if they can't access the GP first to get their termination of pregnancy workup prior to going into the telehealth, dating scan, STI screening, so forth, they can, they're doing an extra consult for those clients for me. So I basically link them in here. Implanons, I'm doing PAP, CSTs, STI screening, self-collect. Menopause is a big world that I am diving into to support women, endo, PCOS, that sort of stuff. But yeah, it's really good and really exciting. The thing that I'm finding is my biggest barrier at the moment is that linking with GP supports and services to do that next step, or pathology, or provide the script once they've had a workup for something, makes it a little bit tricky. So I'm having to network a lot.
So could I ask you, Melanie, if you do, this is fantastic that you've got that liaison with, you know, it's like shared care really with Sexual Health Victoria. Do they organise the ultrasound for you, or can you organise it?
I can't organise it, so they'll send through an order, and they've actually got a really snazzy little system there. It'd probably be worth actually getting them to this forum to speak about it. Yeah. And I actually got onto it, one of your surgeons there, I think it was Dr. Ange, who's also at Monash.
Ange Lou, yeah.
Yeah, because she's on the board at Family Planning, at Sexual Health Victoria. And she might have been a little birdie and whispered in my ear and said, see how you go with this. It's a service that I've heard is coming. And so I linked in with them very, very early. And yeah, it's great. So they'll actually do it all via telehealth, and they send it through electronically or via email to the client, and we have even set up here to do it through Secure through here if they want to send it here, and I can print out their request forms. And I think it was Terry White, if I am quoting her correctly, the nurse that's doing it with Sexual Health Victoria, that they use for the pharmacological packs that head out. Larissa. Yeah, it was Larissa there. And they use Terry White, and it basically goes out in a little pack and is posted to their door. And that has their MS two-step in it, not to mention all their ancillary meds and stuff like that, pain relief and antiemetics and stuff in it for them. It's really, really good.
That's great. That's really creative. And all of these solutions have, you know, been spawned, of course, by the pandemic. But that's great, Melanie. So, you were saying that you feel dead in the water sometimes. Is that also in terms of your inability to get, you know, IUDs inserted and things like that?
Well, I mean, I won't be able to do IUDs, until I'm nurse prac. Sexual health nurses, for everything that I have looked into, are not able to do the IUDs. I mean, also too, you know, we need to have the atropine and stuff, you know, for cervical shock and things nearby, and we don't have drug orders for those sorts of things and stuff. But even like navigating local, trying to get xylocaine and adrenaline drug orders from their GP who don't know me, so that I can use that as a drug order to put in their Implanon, I'm really having to network a lot and set up a couple of pro formas, and I'm getting lots of questions. Or why do you need this? Oh, well, I need a drug order. I'm still an RN who needs a drug order, even though they've come in with their packet of Implanon NXT. That's still not a drug order for me. That's them just bringing a medication to me. So I need a drug order to insert the Implanon, but I also need a drug order for the local prior to that as well. So I'm navigating a lot.
Yeah. So is the idea that they would employ a GP, they just can't, or they haven't got one, or is it that they are only funding yourself?
Yeah, with the funding, they're only funding myself. I know that St Regis Health Services would be very happy to have and employ a GP at our GP clinic, but if you know a GP that would be happy to work for a non-for-profit on an hourly rate and not be claiming their high MBS items and all that sort of stuff that they have access to in private practice, that's where our limitations are. So, yeah, even like if I'm doing the contraceptive workup and we decide, look, you know, this one looks like a really good avenue and pathway for you, I then can't support them any further by then going to a GP here on site and saying, look, here's all this, there's no contraindications, they look really good for Implanon or oral contraceptive or Depo or whatever. I'm then having to then try and navigate our local GP providers to see if I can, because most of them don't have a GP, or they can't go unless the GP bulk bills. And up here in Mildura, we actually no longer have any bulk billing clinics. It's only under certain criteria, healthcare card, pension card. Otherwise, all the others are advertising as private billing clinics. So that can be a barrier for clients. One, don't have a GP, and two, if I can try and get them into a GP clinic taking new clients, they don't have the gap to cover the fees to get a script for something, or to get, you know, a pathology form to go off for their full STI screen. I only have access for STI screening through VCS, chlamydia and gonorrhea, in conjunction with their CST, although if they're under 30, I can still do annual chlamydia and gonorrhea STI screening for them. But if they're outside those eligibility criterias, I need a path form and send them to another pathology service, so therefore I need a GP.
Yeah, your story is you know, really illustrative of how not all hubs are equal, and how the narrative is that the Victorian government's developed all of these hubs. But you know, you seem to be the proverbial little duck on the pond, you know, just paddling away there, trying to get as much traction as you can for your patients. But you need that pairing with the in order to, you know, a catalytic pairing with a doctor, don't you? There has been a suggestion from Amy. And
can I
just want to draw attention to a resource, Kath, that Amy from Clinic 281 has shared with you, which is virtual ED, which
yes,
I heard about. Yeah, was that what you were going to talk about too, Kath?
No, I'm going to say, Mel, please get in touch with me. My GPs are already set up with other services to provide the backup that you need on a bulk billing system. So please, yeah, I have excellent GPs who are very well versed in health, and who we are trying to do this a little bit across the state.
Yeah. So, Melanie, you might be able to use the virtual ED, which I've heard is really useful. But are you really saying, Kath, that La Trobe will help out Sunraysia?
Yeah, so we already tried to, I understand DPV are struggling with staffing at the moment, and we have already tried to support them in this
Where, sorry, Kath?
DPV, Broadmeadows, Mill Park.
Oh, DPV, yeah.
So we've already started the process, or tried to start the process with them. It's not necessarily working out, but we do teleabortion in particular. We have a site at La Trobe University, so we're doing teleabortion on their behalf. And Dr. Romy Giles in particular is very, very experienced in telehealth, in teleabortion in particular, and is very keen on supporting in a bulk billing capacity. So being a service that supports people who need it in the communities that need it. So please, Mel, just send me an email. I'll send you my email address, and we'll start the conversation about setting something formal up, because this is something that we are, as a service, very much committed to, and my practice manager is really, really committed to.
That would be awesome.
Put your contact in the chat, Kath. So what was that, Mel?
I was just being very facetious. I said, I'm so excited. If my pelvic floors weren't intact, I may have just wet myself. That would be amazing. Yeah, but yeah, that's sort of where I'm stuck. And VVED, I do that. I did use it a lot with forensic medicine stuff as well, and I now have utilised that service as well. So that is somewhere that I go. It's just can be disjointed at times, and also too particularly for termination of pregnancy and stuff workup. When you get an ultrasound or an X-ray request through VVED, unlike PPCCs and the UCCs, that's not all covered under that funding. So from a VVED perspective, I've had someone go before and actually then had to be charged the private fee for the scan or the X-ray, and so therefore then that's a barrier. Too.
Really great.
Send me an email, Mel. We'll sort you out.
That'd be amazing. I'm super excited.
This is great
That's a
synergy.
network.
And this is what a network is all about, you know, like a community of practice where we help each other out, and we're gaining an awful lot of information, you know, about how we can develop these models and help the emerging and the established hubs to improve their services. We'll go offline, Mel, and have more conversations with you about how we could support you in Sunraysia as well, and maybe see about other solutions for you. But thanks so much, Kath. I'm just really aware it's nearly 10 to 7, and wondering if other groups from around the traps would like to talk about what's happening in their area, any good news or any challenges that you're facing at the moment. We haven't got anyone from DPV or from Nexus, newer ones, but I wonder, Heather or Amy, tell us how things are going in Clinic 281. You're muted, Heather.
Must be your settings, Heather, I think. Maybe. I can't get her up to me. What about
maybe Amy could talk about Amy's
Heather works out there, or Amy. I'm also thinking the nurse practitioners in the room, you know, how you're going with prescribing. It's the other thing. That's a recent, you know, it's a few months now.
Yeah, I can talk a little bit about it. Just from a Bendigo hub, we've had some incredible changes in 2024. We had a massive organisational restructure and a new CEO who absolutely is all over sexual and reproductive health, coming from more regional community health services up the Murray. So we've had some big changes. We've actually had some new staff start due to staff holidays. We've also got a new doctor starting who is coming from the women's next week, who's doing sexual and reproductive health and also refugee health. So yeah, we're doing we're probably doing the same, if not a little bit more in terms of MTOPs. We're starting to do some VMAs, but one of the barriers, and I'm really interested and curious about people who do VMAs. Yeah, so the very early ones without the ultrasound, is that we're still finding, and this is around GPs, we're still finding people having very, very early ultrasounds with virtually nothing to see. And therefore, because they've actually had an ultrasound, and there's nothing to see, and nothing can, and an ectopic pregnancy can't be excluded, then we can't do a VMA realistically on that. Kath, did you want to say something about that?
Yes, we routinely do VMAs, and we are currently doing a clinical audit, and I'm planning on presenting, and we're going to ethical approval for a proper study into VMAs. Our attitude is that, because we do bedside ultrasounds, we do our own, so we only refer for formal ultrasound if we're going, this is wrong, this is not. Otherwise, if they're under 5 weeks by dates, we don't even bother with an ultrasound. If they're over 5 weeks, we'll have a go and see if we can see something, but we're not really bothered. And if they are don't have any significant risk factors, so they haven't had a previous ectopic, or they haven't had any fallopian tube pathology, or it's not IVF or you know, they have fertility issues, then we will go ahead. We just do extensive education around the risks of ectopic and what that means, and are very much saying, look, this is the reality. This is why people wait. This is why doctors are broadly not willing to do VEMAs. And so do you have, you know, where's your support people? We sort of do that whole risk assessment, and if they're low risk, we just go right ahead.
So Kath, that's
on
really sorry.
Can I just say the early analysis of our data, which is not huge, it's not representative, we're talking about a couple of hundred, is that actually our complication rate is higher among full ultrasounds than VEMAs.
Well, that's supported by the very big cohorts coming out of BPAS in Britain during the
basically
pandemic.
You need a GP who's willing to take on the risk.
Yeah,
So,
that's right. Yeah,
it's
that's
interesting
right.
you talk about that, and again, we'll come offline and talk to you a wee bit more about that, Kath, because I mentioned Frankston's hub, the Peninsula hub, and their increased workload post the whole Hampton Park debacle. But they are also reporting this really large number, you know, really good proportion of their patients are coming really early. You know, they're menstrually aware, they've got early pregnancy tests, and they were actually previously being, you know, penalized for that, because then they were told to wait till there was a fetal heart and all sorts of nonsense. So we are starting a protocol for VEMA with them, and we could combine our data and increase our power. So
thank you. And also Clinic 281 originally do no ultrasound. So it'd be great to combine this, talk offline, but also just as a slight connection to what Caroline was saying earlier, we are seeing a significant percentage of the people we are having to refer for surgical wanted medical, but were delayed.
Yes,
by
GPs,
and so have ended up having to have surgical. And I think there's a really interesting piece of research there around what percentage of people ending up with a surgical in that 9 to 12 week range wanted to go medical and got delayed by outdated processes.
Yeah. So very interesting stuff. And so I just want to feedback in the last 30 seconds that, you know, just congratulate the energy around the virtual room here tonight. There's so much wealth of information from you all, and
just see if Heather or Amy want to, because we invited them to speak. We don't want to cut you off.
Yeah, have you?
I don't know if I'm sorry to put you on the spot, Heather. It still looks like the same problem.
I don't think Heather can get hers to work, but it's Amy.
Hi, Amy.
Hi, sorry, I'm not as good as talking as Heather. She's got lots more information.
She's still talking.
we do, like as Kath said, Dr. Kate is quite happy. She's very experienced.
Yeah.
She is happy to go ahead, but we are seeing, like she said, clients that are sent to after a second, they've had to go back for a second ultrasound and wait before they then come to us, even though you know it's a confirmed with blood tests or whatever else. And we have had some bad experiences where GPs just won't refer. We've had, it's been a bit iffy around the area where they haven't been told that they can't do it, or they've got to go to Melbourne. So we're trying to get the word out there that we are there and send them to us. But but mostly we have had a good response, and work closely with, I think, 1-800 My Options. Send them, they sort of look on the website and find from that. But I don't know what else to say. But it's been I think we've got the name out there, and we're quite busy and continue to be busy. And we have got a few doctors' clinics that are quite good at referring. We've just got to let them know that they don't need to have the ultrasound. If it's a confirmed with a urine or a blood and they want to come across, then they can come across and we can sort out from there.
And Carolyn from 1-800's just made a valid point in the chat about we really do need to sort of get someone. It would be a really good piece of work if we would get some kind of analysis about our patients dropping out because of this cascade of care and, you know, basically obstruction through not being updated in their practice. Yeah. It's 7:02. When is our next meeting? The 27th of August.
Yeah.
And
End of August. Yeah.
We're really interested in any requests for a topic next time.
Or a case study.
Or a case study. As I've already mentioned that we'll be going offline and contacting some of you to progress some of the great work that you're doing and see how we can help you and get some ideas from you about how we could develop perhaps a course for which we could claim a scholarship or put in a bid for a scholarship to help you all. It's been an absolute joy reconnecting with you all back in the Southern Hemisphere.
Oh, Holly.
I have a great case study for the next meeting, says Holly Timms. Great.
I'll catch up with you anyway, Holly.
Kath, have you got one last thing to say?
I've got one last thing to say. I, through some kind of act of God, managed to grab Kim Arthur, the exec director of Women's Health at the State Department of Health. Anyway, she's now my best friend. And I have presented to her the very strong argument that we should have ultrasound and ultrasound trained practitioners in every hub. And they have that, they have the money, the details on that, they have the dollar signs on that. Anyone who's in a hub, please just like casually reach out and be like, hey, this would be something just to keep the pressure on. I saw her on Thursday this week and pressured a little bit harder, but they're interested, they're keen, they recognise the value, they're excited, the minister is excited about the concept. So we just need to keep pushing on this. It's affordable and it's amazing. If anyone in the hub could just, you know, randomly email the department and be like, hey, this is important, that would, I think, just keep it on the agenda, keep it in there.
And I think the department wants another consultation with all the hubs, so we could use that session, don't they? Yeah.
Well, and I'm also thinking, Kath, just on the back of what you've just said, that we've got a community of practice for the nurse and nurse practitioners in the hubs next Tuesday, and the health department are going to be there, Millie and Miller, which are not at the level of, but yeah, they're keen to hear those messages too. So we'll find a way to.
Danielle, did you have something final?
Just on that issue. On the Victorian Women's Health Advisory Council, they're about to start the LARC and Abortion Access Subcommittee, which I'm chairing. And these kinds of issues, like the ultrasound, are very useful to hear about. And if Kath can drop me an email, I can put it on the agenda of the meeting and raise it in that capacity there too.
Thank you very much. Excellent, excellent. Okay, well, good night to you all.
Great to see everyone.
Bye for now.
Take care. Talk soon.
Bye now.